Good morning, everybody. My name is Leslie Nelson Bernier, and I have the privilege of serving as the president of the UNC Health Foundation. And it's a real joy to welcome you today to the third in our series called COVID-19 Game Changers. For those of you that have been with us before, welcome back. And for those that are joining us for the first time, you are in for a real treat. I'm going to walk through a couple of housekeeping items as we're getting started, and then I'll introduce you to our speakers and to Dr. Burks. But I'm sure you're all pretty used to meeting by Zoom by now, but at the very bottom of your screen, you'll see this black bar where you can stop and start your video, mute and unmute. If you'll just stay on mute while the speakers are talking, but feel free to share your video. There's the chat feature that we've enabled, and you're welcome to submit questions. Along the way, our presenters will be happy to answer them, or we'll be happy to ask them on your behalf. And then, of course, you'll also be able to see the participants that are in this meeting with us today just by clicking on the Participants tab. If you need anything else while this event is going on, you are welcome to email us or to text or call at the numbers listed below, and our staff will be happy to help you. And then lastly, I just want to read our disclaimer. This webinar is being recorded. It is for general educational purposes only and does not constitute nor claim to be medical advice. Transmission of information is not intended to create a clinician-client relationship. So with all of those housekeeping items behind us, it's a real pleasure to introduce you to our speakers today. And I'll let Dr. Burks say a few words about our COVID-19 response, but I just want to quickly tell you a little bit about who you'll be hearing from today. And I'll start with Dr. Luther Bartelt. He's an assistant professor in medicine in our Division of Infectious Disease. His particular area of expertise is in intestinal infectious organisms with a complex pathogenesis, particularly in tropical medicine. He also takes care of immunocompromised patients. Dr. Bartelt grew up on a farm in Iowa in a town of less than 200 people. And ironically, it's just 15 miles from one of the largest Tyson facility COVID-19 outbreaks. Dr. David Margolis is a professor of medicine, microbiology and immunology, and epidemiology. He serves as director for our program in translational clinical research. He's also the leader of CARE, the Collaboratory of AIDS Researchers for Eradication. Dr. Margolis' life work has been centered in the field of HIV research with the hope of eradicating this disease. Dr. Margolis has many fun facts about him, but one that I love the most is that he's run the Krispy Kreme Challenge with his son for 7 years in a row. For those of you that don't know about that, you eat a dozen donuts and run a 5K race. It's pretty fun. And then lastly, Dr. Jo Eron. Dr. Eron wears many, many hats for us. He's a professor of medicine and an adjunct professor of epidemiology. He's an internationally recognized and celebrated researcher, teacher, and clinician. He treats people living with HIV at the UNC Medical Center's Infectious Diseases Clinic. He was named our chief for the Division of Infectious Disease in January of 2019. It's his team in the Infectious Disease Division that is really at the forefront of our fight against COVID-19. And as if Dr. Eron doesn't have enough of a challenge managing all of these hats that he wears, he and his wife have 7 children. Only 2 of them are left at home and they're college age, but he also has 5 grandkids and welcomed the most recent one only 2 weeks ago. So I'm delighted for you to get a chance to hear from these 3, but before we get started with that, I'd like to turn it over to our Dean of UNC Health and CEO of the UNC School of Medicine, Dr. Wesley Burks. Dr. Burks?
Leslie, thank you, and thank you all for the opportunity to be with you again. I hope the updates that, like we're listening to today on the COVID-19 Game Changers, have been as meaningful for y'all as they have been for me, because I've really learned a lot from them as I've listened to my colleagues. It really is an honor and a privilege to serve alongside the 3 panelists today. You've heard a little bit about them in the introduction. You'll see the passion that they have for what they do as they talk in a few minutes. Over the last several months, really since mid-March, we've seen the institution, my colleagues, tested on a daily basis in ways that it's just hard to imagine if we'd had this discussion 6 months ago. And it's hard to be prouder of a group of people that I've been fortunate to work with in the care that they're providing, the high quality care, the comfort that they're providing patients all across UNC Health, and I'm thankful for that. Even compared to 2 weeks ago, we continue each day to get a better picture of what our future will look like. And I'm thankful now that we've been able to resume some of the procedures and surgeries that had been delayed due to the pandemic, that many of y'all, many others had to delay care, and that obviously didn't feel good. Our big commitment to you, to the patients that we take care of, to our colleagues that we work with here, is to make sure that our hospitals and our clinics are clean and safe, that if I go there, like I did this week, that I'm comfortable in the context that I have. And that for the people that we work with, that they're not taking care of themselves. They're not getting back to the health where they need to be because of the fear of contacting COVID when they come to our institution. I've said many times in the last few months, one of the things that gives me great comfort is in working with colleagues like Luther, David, and Jo. Their expertise in the area of COVID and epidemiology and infectious diseases, they've been working in this area for decades, and this is just their time to be able to even more so show y'all, show our communities, and show the world what they're doing, which is really pretty amazing. So as we get started, I want to ask Luther, David, and Jo. We'll start with Luther, just how you're doing personally. How has this COVID pandemic that we're all experiencing, how has it affected you and your family? So Luther, please. Thank you.
Good morning. Thank you, Leslie and Dr. Burks, and thank you all for today. Has it really been 3 months? When I reflect on where we are from where we were, one thing has been a motivation change from one of despair to one of hope. I was consulting on the Transplant Infectious Diseases Service when COVID-19 arrived in North Carolina. And at that point, the pandemic was no longer a whisper of something somewhere far off, but it was right here in our backyard. So we scrambled to get access to experimental drugs like remdesivir that we hoped would offer some benefit. But with many efforts, including efforts from David and Jo, we really were left with many blind alleys, very little drug in stock, and cases in metropolitan epicenters really surging at the time. So another therapy we considered was using antibodies from healthy donors to treat the sick. And one way of doing this that we've done in clinical practice is through infusions of pooled immunoglobulins that we hope contain antibodies against infecting agent. Since this virus was novel to the human population, pooled immunoglobulins just weren't available. But thanks to UNC Health Foundation donors, the Blood Donation Center, and a really amazing dedicated staff in the HIV Clinical Trials Unit, Cure Center, among others, we were able to shift operations to initiate a program that could provide this type of therapy through targeted plasma collections from COVID recovered patients. And we'll talk more about this later, but we've been able to treat more than 50 hospitalized patients in just the last 6 weeks. And we're beginning to see early signals in published literature that hospitalized patients who receive plasma might do better. So on a personal note, what gives me a lot of hope is the outpouring we've received from the community of COVID recovered patients who volunteer their plasma. And it's really quite remarkable how freely individuals throughout the country have offered a chance to heal more than 30,000 strangers, some of whom may be very different from them in many ways other than a shared blood type and experiencing a SARS-CoV-2 infection. At home, I witnessed this pandemic unfold through the eyes of my 5-year-old son, who I see a lot more now, that my wife and I, my wife is also a faculty member at UNC, watch him grow up by the day at home. And he seems to have a far easier time adapting to this pandemic world than I think either of his parents are. Pleasure to be here today.
David?
Luther spoke very well, and I wish I had given this probably as much thought as he probably just did. So my reflection, it's been a very strange time. for me, and very reminiscent to me, of when I began in medicine, just finishing college and just starting medical school, and an unknown disease, which became later known as HIV or AIDS, hit the papers and then the hospitals and clinics. And very similarly, in a lot of ways, although moving much, much more quickly than HIV did. It's a scary time where you have sick people that you're really not sure how you can help them and what you can do. It's been very exciting that all of the tools in medicine and science and in how to do experimental medicine that we really learned dealing with HIV over 30 years have allowed us to really respond very rapidly to this really great challenge. And I have really every confidence that we will be able to very rapidly develop therapies, antibodies, and vaccines to help us deal with this pandemic. But I think the big problem is time and the community's response, every kind of community, that we really deal with this the best way, because it's not going to come easy or rapidly. And so we have to sort of work our way forward. I'm really happy to be able to contribute with Luther to this plasma program, because it is sort of low-hanging fruit, something that's very satisfying and I hope is helpful, and we certainly will learn important things from it, as well as hopefully improve some patient care. So that's been a rewarding thing.
Yeah, I'll just go ahead. This is Joe. Make sure I'm not muted.
You're good, Joe.
Great, thanks. Well, it's hard to add to Luther and David. I think I've been so impressed by the people in our healthcare system working on this problem. To see the nurses in our COVID units who are literally in with the patients, all dressed up in their personal protective equipment or PPE, which has become like a pretty, it's like a ATM, PPE, everybody knows what that is. To see them in there with the patients, that our intensive care physicians have been unbelievable. And we've had some incredible patient stories. We've treated several pregnant women with remdesivir. Luther, I think, treated the first one and went through the process of getting that medicine really, really rapidly. We've had some incredibly sick people leave the hospital, which we didn't think was going to be possible. And our, the various research groups, the people that, want to develop new therapies, have pitched right in. I mean, the work being done of just in the, DrBurks mentioned, being able to go and get routine healthcare. Well, David Wall and others in our group set up these testing centers. And I know you heard from David Wall a couple of weeks ago. So now I heard today that our surgeries today we're 85% of capacity. People who need surgery are getting surgery. Tomorrow, we're actually going to exceed pre-COVID numbers in terms of the people getting surgery that need it. So I think it's really the way people have worked together. I don't know if brave is the right word, but really being so dedicated. So I just very much appreciate that. All right, great. I get to give a quick summary. I think the best thing about this program that Allison and Leslie have put together is the time for questions. So I think you've had a lot of updates, so I'm going to go pretty quickly. I love this slide because it's so colorful. And for anyone who's interested, the slides can be shared. You can go to the website. I think probably everybody knows that the disease has this tremendous spectrum. Obviously, people get very, very sick, and obviously a lot of people have died. But we now know that some people are asymptomatic. Some people probably remain asymptomatic, never become symptomatic, and then there's a whole lot in the middle. Next slide. I wanted to show this just because most of you, I'm sure, not medical, but I think these two pictures, this first one and now the second one, tell a story. The first picture is someone who's really got intensive COVID infection in their lungs. And the CT scan, looking at the lungs, pretty easy. Black is good. Black means there's a lot of air in there. White is bad. White means the lungs are full of fluid. And the first person is in the ICU and can't breathe. And then on the bottom of the right is someone who actually left the hospital, was actually in the hospital for a different reason and got the scan and was found to be positive for the SARS-CoV-2 virus. And you can see just little tiny patches of white down there at the bottom. And it's just, it affects people differently, and we honestly don't know why. There's some clues. Next slide. But we don't know for sure. This is a great website. Again, this dashboard put up by Johns Hopkins. And this is now 2 days old. But over 7 million people across the world, 400,000 people have died. In the US, I'm sure we've crossed 2 million, because again, this was 2 days ago. And it really, and well over 100,000 people have died in the US. It's an incredible epidemic, and moving quickly into South America. It's going to move into Africa. It is a true pandemic. Next slide. COVID has become the #2 cause of death in the United States. It may be #1 now because this slide is a month old. Next slide. In North Carolina, unfortunately, we're not kind of past the peak. New York City, Seattle, other places are past the peak. We're not past the peak. In fact, this week and last week, we've had more hospitalizations in North Carolina than we've had any week previous. On the map on the left is just the various counties. Probably you all live in some of these counties. The one dark blue one in the eastern part, that's Wayne County. It's a small county, but has many, many cases. And obviously you can see Durham and Wake counties right there in the middle. On the right is number of deaths. And it looks like it's going down, but that's a reporting phenomenon. It's not going down in North Carolina. And we're ready. The healthcare system is ready to deal with it. But I think one of the things that Luther mentioned, it's worth talking about, usually there's anxiety when an epidemic starts. Then there's optimism and we can do this, and I think Luther expressed that. And what we have to be careful about is there's the downhill part where, boy, we have to keep being ready, keep being ready, keep being ready. That's tough. And supporting our healthcare workers, the people we work with, the nurses and other people that I mentioned is really critically important. Next slide. The reason why COVID-19 or SARS-2 is so infectious is the amount of virus in the nose is incredibly high, and in the upper airway is incredibly high, and that's why transmission is so high. The farther those bars go to the left, the more infectious the virus is. And this compares SARS-2 with influenza. And what it shows is that the virus count is much, much higher in SARS-2 than in influenza. Next slide. I'm going to say just one word: masks work. There's no question that masks work. This is a picture. There was a patient, and this is in China, that red box. There was one patient there. That was the only patient in this open area that had COVID. And there were 70 healthcare workers and 50 other patients in there. But everyone had a mask on, everyone. All the patients, all the healthcare workers, no one else got infected. And so masks are incredibly important. You wear a mask to protect other people. That's such an important message. It's not, it may protect you to some extent, but it's to protect other people. Next slide. We have treatments. I'm not going to go into it. Luther mentioned remdesivir. We have remdesivir now. I think we've treated 90 people in the healthcare system. We hope to continue to get remdesivir. It does work. It just works modestly. It's not a cure where you give it and the person picks up their ICU bed and walks out. That's not what happens. But it does help. Next slide. What really will do this is vaccine technology or other preventions and treatments that David and Luther will tell you about. The UNC system, has been chosen to be help roll out the first vaccine study. We hope to vaccinate in a study between 500 and 1,000 people. It'll be a randomized comparison, but we're gearing up for that. Next slide. And there's a lot of treatment and prevention research going on at UNC. We have several treatment trials. We have the convalescent plasma that you're going to hear about. I just mentioned the Moderna vaccine, which will start hopefully in July. And then Mike Cohen and his group, along with Christopher Hurd, who works in our division, are developing these monoclonal antibodies for very high-risk populations as a prevention. And I think I have one last slide. That's it. But what I really want is I hopefully we'll have time for questions, and we're really excited to actually take questions. So thank you very much.
Okay, Luther and David, if you guys want to get started, and then we'll save our questions for the end.
Okay, sure. Thank you. So as Jo had mentioned, one of the therapies we're using in the hospital right now is this convalescent plasma, and I thought showing a graphic a bit of what that process is and some of the concepts behind it would be helpful. When we say convalescent, what we mean is the period of time when someone has recovered from some infection, in this case COVID-19, as shown in the green figure in this diagram. And when we draw plasma, that's the liquid part of the blood with all of the cells separated back from it and given back to the donor. And the hope is that this plasma contains antibodies that are capable of neutralizing the virus and therefore speeding the recovery of a patient who's acutely ill. On this slide, we have Tom Nish from our blood donation center next to one of the units that are used to draw this plasma in a process called apheresis. And to date, we've been able to collect from 72 different donors through a quite robust donor recruitment process. And there's a QR code at the bottom of that slide if you're interested in seeing more about becoming a plasma donor or referring people to be plasma donors. And then Brian Gurney in our clinical trials unit has really gone the extra mile to get patients enrolled into the plasma therapy program. And through these efforts, 50 patients have been treated in our hospital, including 4 children from the pediatrics group. And more than half of those patients have been just in the last couple of weeks. Next slide. So the way we are currently administering plasma is through a national program called an Expanded Access Program that's FDA authorized and operated out of the Mayo Clinic. And really for treatment of patients hospitalized with severe COVID-19 on the wards or in the ICU. And on this map here are all of the hospitals throughout North Carolina that are registered with the Expanded Access Program. One of the differences in our program compared to other hospitals is that our blood donation center is the only medical center that's collecting our own plasma on site. And we found that the time from plasma request to infusion is very rapid for us, within often 6 or fewer hours, whereas other hospitals that are participating in this program through connections with the American Red Cross or other regional blood centers may have patients waiting longer to receive plasma. So we hope to be able to the extent possible, expand some of our program to be able to make plasma more rapidly available for patients across the UNC Health system. And just recently, we actually were invited to represent the Southeast region in a large multi-center efficacy study, so we can understand really what plasma benefit is in these patients. Next slide. And with our collaborations with world-class experts at UNC in virology and antibody biology, we're beginning to understand some about the immune response in healthy individuals as well as those who are sick in the hospital as it relates to these antibody titers. So this is a graph showing dots and squares along the horizontal line in the bottom, each of our different donors. And then on the vertical axis, we are showing the levels of antibody titers to some specific antibodies of the SARS-2 virus. And you can see there's a range of antibody responses across these donors. And this has led us to develop our own randomized control trial where we want to better understand the optimal benefit of some of these very high titer range donor units and be able to really dissect the mechanism whereby plasma may be most beneficial for these patients. I'll pass to David if you want to add more to this.
Sure, just to make a few comments. So the implementation and design of this study and that we're doing here uniquely at UNC sort of, I think, speaks a lot to some of the unique challenges to where we are in dealing with COVID and some of the unique advantages to be able to work here. So there's really no proof yet that giving plasma, this kind of plasma with COVID or SARS-2 antibodies in it, is effective or helpful, or who it's helpful for, or how much to give, or how often, or when. At the same time, while we have sick people, we have very few therapies. When we started this program, we had no therapies that were proven to be helpful. And so there's sort of an ethical tension of something you think might work, but it also might have some risks, but we just don't know. And so in many settings, it's very difficult to study something in a typical way by giving one group of patients something like a test article like plasma and other patients nothing, and just watching them and wringing your hands. So because we have Dr. De Silva's lab here, he's studied dengue and other infectious viruses for many years and is an expert on the antibody response that people make to viruses. Very quickly, he was able to spin around his lab to look at the antibody responses to this virus. And those are the yellow dots you see. And we also have Ralph Barrick, who's been a coronavirologist for over 30 years. Coronaviruses had generally not been paid much attention to. And Ralph was this sort of dedicated scientist out there in the wilderness doing things that no one else was interested in before the first SARS showed up from China 15 years ago. And then another virus showed up in camels called MERS. And now we have SARS-2. And so Ralph's lab is able to instantaneously develop a new assay, not to measure antibody, but to measure how an antibody can block infection. That's the neutralization titer. That's the purple dot. There's very few places in the world that can do that assay. So we're lucky to have it here at UNC. And so we can look at plasma from different people and compare the total antibodies of a certain type that you see in the yellow dots to the ability of antibodies to block infection in the purple. We don't know whether the purple dots actually tell you that this antibody will make someone better if we give it to them, but it's our guess that it should. We hope it will. And it would be really great to be able to correlate the yellow dots, which is a much easier test to do than the purple dots, which require a big biosafety lab, of which there's only a few around. And then we would know what kind of antibodies and what kind of plasma might be useful if it turns out that plasmas that are in the green box are clinically the best and the ones that are in the yellow box are not as good. We're not even using ones that fall below in the white area because we already suspect that those level of antibodies is not sufficient. So our study is comparing essentially yellow box plasmas to green box plasmas. This way we give something that might help everyone in the study, and we get to sort of compare high versus low. There are risks to giving plasma as well, so we can also look at the different risks of giving sort of higher level antibodies than lower. This might tell us that these kind of antibodies, the ones that are illustrated in the yellow dots, are the ones you really need to have. And that would guide the development of synthetic antibodies. This was a study that Jo talked about that's being used in prevention, and would guide vaccine studies, because vaccines would be then designed to make the kinds of antibodies you see in the yellow dots. And that's one of those is the Moderna vaccine, the first one to roll out, as Jo talked about, in the next 2 months or so. So this is a really, I think, satisfying way that we can get something to people right away that might help them in a way that we learn really important information.
That's great, David. Thank you so much to you and to Luther and to Jo for sharing your thoughts. You all participants were kind enough to submit many questions beforehand, and then I see there's a couple in the chat here. But before we do that, I'm going to turn it back over to Dr. Burks for just a second to address a couple of questions for David and Luther and Jo.
Okay, thank you, Leslie, and thank all of you for the thoughts that you've just given us. I'll ask each of you a question based on the questions that were sent in and also feedback from the community. So Luther, I'll start with you. So what are your expectations as an infectious disease expert for how long in our community, say the Triangle, that we'll really be seeing COVID here? What is it? How many months? What does it look like?
That's a great question. I wish I were an epidemiologist.
They wouldn't be able to answer it either, Luther. You might as well give it a shot.
Make it up. Go ahead.
You know, I think it is going to be a bit of a moving target. We have to keep a very close eye on it. We have already seen that, you know, models to try to predict where the epidemic curves go can be helpful and also can have limitations. And I think, you know, we've seen over the last few weeks a pretty steady flow of patients in our hospital, and I would expect that to continue at a steady pace, with the possibility that we would have, you know, some surges at various times throughout the next year. So I think, you know, Jo maybe helped me answer this question in one of his earlier slides, talking about the optimism we have when the curve plateaus and when it starts going down, but also maintaining that readiness that things could change, and I feel like we're in a position to be able to respond to that.
Okay, good. So David, I'll ask you a question now related to the vaccine. So we see lots on the news, and every night on the national news, there's something about a vaccine coming. Joe in his presentation talked about kind of the different platforms. Again, from a physician standpoint, what are your realistic expectations that, not in a study, but that I might be able to receive the vaccine as a patient? What does that time frame really look like?
Oh, Joe has been more involved in these discussions than I. I think there are a lot of vaccines in development, and there's a lot of the problem in developing vaccines is often that it's economically very challenging because it's very expensive, but there's often not a very big market for that. In this case, I think that's not going to be such a problem because of all the social and governmental support. And so there are numerous vaccines being developed in many countries. And I think that we will probably have a large number of vaccines available, which is going to be helpful because we're going to have to vaccinate an unprecedented number of people. But the speed of it, is, I think, very hard to predict. I think that a year is probably overly optimistic, and 2 years is probably somewhat pessimistic. So somewhere in between there is what I would sort of guess. But I think that's a poorly educated guess. I don't know if Joe wants to add to that.
Yeah, Joe, you got additional
exactly
thoughts?
the same thing, really. I would have said, optimistically, a year from now, we might have 1 or 2 vaccines. That one of the reasons the vaccine that we're going to work on, it was chosen, is it's pretty scalable. So one issue is how quickly can you, get up. With influenza, you worry about running out of eggs, because so the Moderna vaccine is pretty scalable. But I agree with David. We're going to need probably multiple different vaccines in order to scale it. If everything works, I think optimistically a year from now, probably what would be great is for the winter virus season beginning in late 2021. That would be a great time to have this vaccine. So that would be about 18 months from now. I think it's possible. I think the vaccine will likely, I'm very optimistic that it'll have prevention effectiveness. I don't know how long it'll last. That I think is a big issue, and why we're exploring these monoclonal antibodies, especially as we get older. Our immune system doesn't seem to respond as well to the coronavirus creating immunity. So that's but it's a great question.
Okay, so all of you, but Joe, I know you're more intimately involved in this part. You talked about the Moderna vaccine coming in the next few weeks locally. Will we, the people on this call, will we have an opportunity to volunteer?
Yes, that's an easy one. We don't have the exact protocol yet, but we will be able to attract volunteers. They want higher risk people, but they haven't defined it. Unfortunately, Wesley, you and I are probably higher risk people based on age. I think Luther's out, but Leslie, she looks really young, so I'm going to say she's out too. But yes, there will be an opportunity, and we're kind of working that out. We want to collaborate with our the wonderful retirement communities around Chapel Hill. So yeah, yes, no question.
Okay, good. So what you alluded to, Joe, and this is, I'll go back to Luther on this one. In the initial studies that came out of China, then what we all heard is that there was, starting at age 60-ish, in each decade, an increasing, pretty significant rise in the death rate.
Mm-hmm.
And so now we've got data from the US, like a whole lot more information in the last 2 months. So there's age, and then there's other cofactors of obesity, hypertension. So has that played out what I just described, or are there other risk factors that we've discovered that weren't apparent at the beginning?
Yeah, I think that's the risk factor identification we've had, to this point. We also know that there are certainly risks related to maybe factors that we don't always measure clinically that we're still needing to learn about. Why some individuals in a younger age category are seemingly having severe disease and others handle the disease well. And we've learned from New York that where you live and how you live may influence the disease severity as well. And I think we really have to look carefully at those factors in a state like North Carolina.
Okay. Along those same lines, Luther, as you answer that, then there's a group of people that are asymptomatic. There's been a little kerfuffle in the news this week with the WHO about how many people are actually asymptomatic and their likelihood of transmission. So can we tell anything right now about the people that are asymptomatic versus become symptomatic? Is there anything about that person that would put them more likely to be asymptomatic versus symptomatic, or not really? It's just an unknown process.
Yeah, I mean, I think age certainly is one of those main factors. If you really take a forest view, children we know can have detectable virus and really show minimal, if any, signs. And I think other factors are probably to find their way. It's really hard to diagnose and follow someone who's asymptomatic. When did they start being asymptomatic? When was their exposure? When did they first start showing shedding of a virus? How long does it persist? And without knowing just that natural history, it is very challenging.
Okay, David, I want to ask you this question. You've partly answered it in the chat room, but in the map that y'all showed earlier, there were a paucity of cases in Africa, Eastern Europe, even Australia. But then the comment was, it's coming to Africa. So is that paucity now from a lack of disease, a lack of reporting? And the second part of that is, why would you say like it's coming to Africa? What about the disease process, the pandemic, makes you think that it's going to happen there like it would have here?
Well, that's hard to answer very precisely. I think generally the virus can find its way into every human population there is over time. Just think of the fact that this sort of boggles my mind when you think about it. This virus came out of an animal and infected a person somewhere in China maybe 6 months ago for the first time. And now it's infected 7 million humans across the world. So it's very transmissible and infectious. But there are clearly places where it spreads more quickly than others. Why it was so rapid and devastating in Italy, but not so bad just next door in Germany, is sort of hard to explain. I think we have a lot to learn about it. But a lot of the missing red dots on the map in some places are very likely underreporting, either intentional in some instances, and just because the reporting systems may not be in place in others. But there are certainly a lot of places where the virus is not yet there enough to make a red dot show up on a map. There are a lot of counties in the US that have had very, very few cases, largely because a lot of those places just don't have many people. But eventually, and this is sort of the challenge, this is what Luther and Jo were talking about, we really need to have our guard up for a long time, because the virus is not going to just go away. And even in places where there's not much virus, there's still some risk.
Okay. So North Carolina has started to open up in the last couple of weeks. Not unexpectedly, the numbers of patients coming into our healthcare system has gradually gone up during the last few weeks. And as Luther and you all alluded to, the numbers of people that are hospitalized right now are higher than they were 2 months ago. So there are increasing numbers of patients. Other states, South Carolina, Georgia, opened up a few weeks before us. What lessons have y'all learned from those states that would help us here in North Carolina?
Yeah, that's an excellent question. I don't know that one of the issues is how quickly do we learn the lessons, right? Because there's a lag time between kind of opening up and when there's transmission. I mean, one of the things that we all are hoping for is we know that the coronavirus doesn't survive as well in warm temperatures. So I think there's some hope that as ambient temperatures rise and that there may be actually somewhat less transmission. So I don't think we've learned anything yet from South Carolina and Georgia. I do think that with the quite a few public gatherings, I think we're gonna see that effect 2 or 3 weeks from now. That's when we'll see it. The incubation period from China was on average 5 days. I think it might be actually a little bit longer than that. We've seen some people that have been exposed, several weeks ago and are just showing up with symptoms. So I would say, Dr. Burks, that probably 2 to 3 weeks from now, we'll have some lessons to learn. I do, again, if we can build a culture of people when they're out and about, and especially in stores and restaurants, and wear masks when possible, because I think that we know in Asia, and Mike Cohen talks about this all the time, in Korea, Hong Kong, China, Japan, where there's really a culture of wearing masks, it really does make a difference.
Okay, good. So a couple of days ago, there was a national publication that had surveyed about 500 epidemiologists, and it listed a bunch of questions that they were asked that made a lot of the different online communities. So one of them that they were asked, and Luther, I'll ask you, but all of you chime in here, was when are you going to be comfortable flying for travel? And so again, we're speculating at this point, but you each have a kind of feeling with seeing patients, knowing the disease. What's that time frame, or what do you think right now based on your best guesses for you personally? When are you going to get on the plane?
I don't have any plans to.
If I had to go somewhere, I would be comfortable getting on a plane. Actually, I'm not so much worried about. I would not take anything that was handed to me from anybody. I would not touch anything that I didn't need to touch, and I would wash my hands before I got on and as soon as I got off. That would be why I'd be rushing to the front of the plane to wash my hands. But I would, if I needed to go, to my brother in Washington Washington State needed me for some, I would go. I'm sure that wasn't the answer of most epidemiologists, but I feel pretty comfortable about how to keep myself safe. But I'm real curious about David, what David Margolis would say. When are you getting on a plane, Dave?
Well, first I'd really need to go somewhere for a good reason.
Yeah, well, yeah, okay.
I wouldn't go fishing. And yeah, I would be willing to do it, but I would be careful the way you're talking about. I guess I'm over 60, but I feel pretty healthy. I think if I was less healthy, I wouldn't get on a plane at all. There's some risk. We do risky things all the time. It's just a choice.
Okay, no, it's good. I mean, there's a range of emotional responses and a range of like a series of questions that we're each going to ask before as we make that decision. But it is important for people that are on the call and others that they hear how you kind of walk through those decisions like that. So this is a little bit more probing for each one of you. Earlier, you talked about some personal reflections on taking care of patients. David alluded to when he started training when HIV first came through and the different responses to it. But something in the last 3 months has surprised you in ways that it may be how people work together, it may be a disease, it may be the pathophysiology. What's that one thing that you go like, oh my gosh, what's really surprised you? So Luther, you want to go first?
Sure, yeah, whether it's a surprise or just a vast appreciation, we all collaborate together in our various research projects, but often we're doing a lot of our own thing, and in just such a rapid time, seeing how the university across multiple divisions, definitely in the infectious diseases division, has really just magnetized, and we are operating as sort of one unit, working together and seeing how really we can accomplish so much when we bring our expertise together. That has been, I think, one of the most gratifying things to witness.
Okay, David, how about you?
I'm sorry, I'm answering a question and I'm not as good as David Wall. So can you ask me the question again?
Yeah, in a personal way, there's something that's really surprised you that you wouldn't have predicted that have come out of this for you personally. It's different for each one of us, whether it be how people work together, as Luther talked about, whether it be like this disease is like in odd ways, it's really cool to learn about it. What's that personal revelation for you?
I guess the personal revelation for me is how hard it is for me to do things without anybody around. I really can't stand Zoom and calls and whatever.
Yeah.
I'm looking to talk with people, but I can't find them anywhere.
That's great.
So, Joe?
Hard to beat that one. Hard to beat. I think one thing that surprised me is how really rewarding it was to go and actually take care of people with COVID and kind of go into the units and just working with the pulmonary, the intensivists, and seeing how they manage patients. It was really just incredible. And then kind of the resilience of the some of the patients has been really incredible. We had a guy who was visiting from New York City, and he also was HIV positive. And I guess one of the really great things was nobody cared that he was HIV positive. He was HIV positive, and he'd been treated, and he was suppressed on therapy, and that just was not an issue for anybody, for any nurse, doctor, nursing assistant, dietary person. It just wasn't completely. It was a non-issue, and he was incredibly sick and almost died twice. And just a week ago, I learned from Claire Farrell that he was actually leaving the hospital. And I actually think if he hadn't been visiting in North Carolina, he might not have made it because New York was so overwhelmed. And we were able to apply this incredible intensive care team to his care. So stuff like this really brings out great strength in people, which I think is really fun to see. Actually, it doesn't sound like, can it really be fun? And it is fun to take care of people and see people really pulling together. I think that surprised me how how much I enjoyed it I think in a good way.
Okay. Oh, one last question before I turn it back over to Leslie. I asked earlier, or we talked about the survey of epidemiologists and flying, but there's also the personal part for each of us online, and some of the questions are related to this. Right now, you would tell each of us, if we go out, to be careful where we go, to physically distant from someone, to wear a mask, to wash our hands before we go, while we're going, when we come back. So those measures that we all know about. But at some point, we would like to go and be around people that beyond like 6 or 7 people that are physically distant. There's crowds that we're around, whether it's whatever venue it might be. Your expectations, again, based on what you've seen, what you know is coming, is that not likely to happen before October, before January, before next April? What's that time frame feel like for y'all?
I'm going to say next summer.
Okay.
But I don't really know. I mean, we're just guessing, and the smartest epidemiologist in the world is guessing.
Yeah. So, okay, that's good. So Leslie, I'll turn it back over to you.
Yeah, we're going to just ask one more question and then we'll go into our closing thoughts. And this one is about contact tracing. So for Luther, David, or Joe, if you all could give an update on contact tracing, particularly in North Carolina.
I think contact tracing is incredibly useful, but it takes a ton of resources. And right now, I think the key is testing and diagnosis of people at risk, and then that have those people, if they're positive, to quarantine. As far as I know, and Luther and David may know differently, we don't have a aggressive kind of statewide contact tracing. I think when students come back, that's going to be part of what we do, certainly in the hospital setting. And I know our Orange County Health Department is very engaged in contact tracing, especially as people move in and out of the hospital. But kind of statewide, I don't think it takes a lot of people to do contact tracing, a lot of personnel work.
All right. Well, on that note, I just want to thank all of you, Dr. Burks and Dr. Eron and Dr. Margolis and Dr. Bartelt. Thank you so much for being with us today. I hope you all have enjoyed this session. I wanted to point out a couple of resources for you. We do have a full COVID page on UNC Health's main website, which you can find there. If you are moved by what you've heard today and are interested in supporting our COVID Response Fund, there's a link to do that. If you're interested in learning more about this study that Dr. Margolis and Dr. Bartelt are doing and ways that you might be able to help them, you can also reach out to us directly for more information with that. Thank you again so much for being with us. If you'll stay on, there will be a poll, so just feel free to go ahead and take the post-event survey and then take off. Thank you so much for being with us and have a great afternoon. Bye-bye.
Thank you.